How's it going, guys? Past level question for hematology, step 1 internal medicine, 2CK, 54-year-old man, 2-day history, cough and fever, sputum sample shows strep pneumo, gram-positive diplococci. Don't confuse with gram-negative diplococci, which is Neisseria meningitis gonorrhea. Leukocyte count, super elevated, 54,000, should be 4 to 11,000. We have a blood smear, I'll talk about this as we move through the clip. Most likely diagnosis, choice A, ALL, wrong fucking answer. And you instantaneously know it's wrong because it's not a kid. It'll always be a kid on USMLE. All right, so they'll give you e.g. 12-year-old who has a leukocyte count of 40,000, 90% lymphocytes. That's ALL. That's it. And the smear will show you uniform light blue cells, your lymphoblasts. The caveat, of course, is that pertussis can look like ALL. It can cause reactive lymphocytosis. So they can give you 12-year-old, has leukocyte count 35,000, 90% lymphocytes. You're like, it sounds like ALL, but they tell you there's post-tussive emesis, vomiting after a cough. There's hypoglycemia, two findings you can see in pertussis. ALL, wrong fucking answer. Choice B, AML, wrong fucking answer. So you would see R rods. Now, even if you think the smear is difficult, you don't know what you're looking at here, I can tell you the R rods aren't there, all right? You don't have to worry about M2 versus M3 with the R rods. Obviously, M3 is going to be APL, 1517 translocation, but if you treat with all trans-retinoic acid, you can cause differentiation of the cells into mature neutrophils. You can also get lysis of the blasts, which can release the myeloperoxidase containing R rods, which can precipitate a DIC, and you can give xanthine oxidase inhibitors, i.e. allopurinol, to prevent tumor lysis syndrome. So they can just tell you in a stem that there's 30% blasts, 50% blasts. That's what they would tell you for AML. So we said for ALL, be a kid, high leukocyte count, 90% lymphocytes. If it's AML, they're just going to say 30% blasts, 50% blasts, and it's an adult. Wrong fucking answer. Choice C, CLL, wrong fucking answer. It's going to be an adult where you get a super elevated leukocyte count, and it's all lymphocytes. So you get a 65-year-old, leukocyte count 50,000, 89% lymphocytes, CLL. You get the same exact vignette. It's a kid, ALL, okay? CLL has some special stuff associated with it, but it's nonsense for USMLE as far as CD5, 23 positive cells, or warm autoimmune hemolytic anemia, or smudge cells. Stuff's truthfully low yield. Wrong fucking answer. Choice D, CML, correct answer. It's a very buzzy smear for CML. I jacked this image from my own hematology PDF, which I'll link in the comments below. I describe this as a motley mix or a soup. It's a medley, okay? Now this is showing us myelocytes, metamyelocytes, promyelocytes. That's what they'll tell you if they list the cells down the center of the page. All the myelo-sounding cells. And you need to know that CML is due to Philadelphia chromosome, 922 translocation, BCR-ABL, forms an oncogenic tyrosine kinase. They can describe it as a fusion protein. You treat with imatinib, which targets the BCR-ABL tyrosine kinase. That drug can cause peripheral edema / fluid retention. And you can get a low leukocyte ALP. Some students get hysterical about that detail. It's low yield, maybe 1 out of 5 questions for CML. Correct answer. Choice C, leukomoid reaction, wrong fucking answer. So the smear would show us reactive granulocytosis, and I articulate that in such a fashion because that'll be the answer sometimes on USMLE for leukomoid reaction. Okay, just reactive granulocytosis, aka all neutrophils. Neutrophilia is what you're going to see on a smear. Now, I'm going to make this real clean and easy because a lot of you've heard leukomoid reaction quite a few times, or you've read it, and you still don't know what it is. Make this real simple. Leukomoid reaction is an infection where you have a leukocyte count greater than 30,000. That's it. Now you say here, what are you talking about, Mike? We have an infection and leukocyte count's greater than 30,000. You're right, but we don't have neutrophilia here. Now, I can tell you that the reason I did this is because I've seen in an NBME question at 2CK level actually, where they gave you an infection on a background of a patient who happened to have CLL in that question. And they gave you a leukocyte count of about 80,000, and it was 90% lymphocytes, and the patient happened to have a strep pneumo. And I asked the student, what's the diagnosis? And they say, well, strep pneumo, pneumonia. I say, anything else here? Because if you have a strep pneumo, pneumonia in isolation, your leukocyte count should be about 10,000. It could be normal. It could be 13,000, 18,000. So if you have a leukocyte count greater than 30,000, you should be thinking leukemia. When you look at the smear, if it's all neutrophils, that's reactive granulocytosis, that's leukomoid reaction. You can also write the mechanism as increased leukocyte release from the bone marrow post-mitotic reserve pool. I'm regurgitating that literally from the NBME exam. But if you do the smear and you see this motley mix, this medley, this soup, this is CML. And you can get a leukocyte ALP that's elevated, whereas in CML we said it's decreased. Choice E, wrong fucking answer. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.